Welcome to this Step 3 review on inflammatory arthritis, with a focus on rheumatoid arthritis. This video is brought to you by Roadmap to Residency. Our goal today is not to reteach rheumatology from the ground up. It is to show you how the exam writes rheumatoid arthritis questions and how to attack them, from the first diagnosis through starting a disease-modifying drug, monitoring methotrexate, stepping up to a biologic agent, and knowing when to co-manage with rheumatology. Keep your question bank and a solid review resource open alongside this video, because these patterns stick best when you drill many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn to recognize the rheumatoid arthritis pattern in the stem and choose the right first disease-modifying drug. Second, we will look at how the exam loves to test the monitoring of methotrexate and the step up to biologic agents when methotrexate is not enough. Third, we will talk about when the working physician co-manages with rheumatology and what that correct answer actually looks like. Along the way, we will work through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to read the stem for the rheumatoid pattern. Start by matching the joint pattern. Rheumatoid arthritis is symmetric pain and swelling of the small joints of the hands and feet, with morning stiffness that lasts more than an hour and actually gets better as the patient uses the joints through the day. When you see that picture, the writer wants rheumatoid arthritis on your mind, not osteoarthritis, which is worse with use and tends to spare those same small joints. Then, once the pattern fits, remember that this exam rewards confirming with the right antibodies and inflammatory markers, and then starting treatment early. On Step 3, delay is usually a wrong answer. When the stem hands you a classic picture, it almost always wants you to act, not to order one more test before doing anything. Strategy 2 is to start the right disease-modifying drug. The single most important fact here is that methotrexate is the default first-line drug for newly diagnosed rheumatoid arthritis, and it is the correct answer far more often than any other choice. Expect the stem to describe active disease, and then line methotrexate up against tempting distractors. Unless a clear contraindication is written into the stem, such as pregnancy or significant liver disease, methotrexate is where you go. Now, the second point. Corticosteroids do calm inflamed joints quickly, but on this exam they are a bridge while the methotrexate takes effect, not a place to camp out. Be suspicious of any answer that leaves a patient on long-term steroids as their only therapy. The stronger answer starts the disease-modifying drug and uses steroids only for short-term symptom control. Let us talk about monitoring methotrexate the way the exam tests it, because this is a favorite question type. First, check before you start. Before the first dose, the writers want a baseline set of liver enzymes, a blood count, and kidney function, along with screening for hepatitis and tuberculosis. A stem that jumps to methotrexate without that baseline is setting up a wrong answer. And always confirm the patient is not pregnant, because methotrexate must be avoided in pregnancy. Second, monitor on a schedule. Once the patient is on therapy, the recurring theme is watching the liver enzymes and the blood count over time. When the stem shows rising liver enzymes or a falling blood count, the next best step is usually to hold the drug and reassess, never to push the dose higher. Third, give folic acid and know the traps. Daily folic acid reduces the common side effects and is often the correct answer. Watch for the alcohol trap since drinking adds to the liver risk, and keep the interaction with certain antibiotics in mind, because that can drive toxicity. These are exactly the details the writers hide in the stem. Let us work through our first practice question. A 45-year-old woman comes to the clinic with 3 months of pain and swelling in the small joints of both hands and both wrists. She has morning stiffness lasting about 2 hours, that eases as the day goes on. On exam, her joints are warm, swollen, and symmetric. Her inflammatory markers are elevated, and testing for the rheumatoid antibodies is positive. The question asks for the most appropriate next step in management. Notice that the stem has already handed you the pattern and the confirming tests. Read the 4 options carefully and choose your answer. Then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern. Symmetric small joint swelling in the hands and wrists, morning stiffness lasting more than an hour, elevated inflammatory markers, and positive rheumatoid antibodies is the textbook picture of rheumatoid arthritis. The stem has already confirmed the diagnosis for you, so you are not being asked to order more testing. Second, apply the rule. Confirmed rheumatoid arthritis calls for starting a disease, modifying drug early, and the first-line choice is methotrexate. Starting it now is what prevents joint damage, and it matches the treat early principle this exam rewards. Third, eliminate the wrong answers. A non-steroidal drug alone with a 6-month delay is too passive and lets the disease damage joints. Imaging before any treatment just adds cost and delay when the diagnosis is already clear. Long-term prednisone alone controls symptoms but never treats the underlying disease. The correct answer is to start methotrexate. Here is our second practice question, and this one is all about monitoring. A 52-year-old woman with rheumatoid arthritis has been on methotrexate for 3 months with good improvement in her joints. She feels well and has no complaints. But her routine laboratory testing today shows liver enzymes that are now about 3 times the upper limit of normal, while her blood count and kidney function are normal. The question asks for the most appropriate next step. The key is to notice that the abnormal laboratory value, not how she feels, is what the question is really testing. Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, read the monitoring signal. The recurring theme with methotrexate is watching the liver enzymes and the blood count over time. This patient is doing well clinically, which is a distractor, because her liver enzymes have climbed to about 3 times the upper limit of normal. That laboratory signal is what the question is testing, not her symptoms. Now, why does holding the drug win? The safe, proportionate next step is to hold the methotrexate and recheck the liver enzymes to see whether they settle back down. Continuing the same dose or increasing it ignores a clear toxicity signal, and jumping straight to a liver biopsy is far too aggressive as a first move. Match the response to the size of the problem. The correct answer is to hold methotrexate and recheck the liver enzymes. Now let us step up to biologic agents. First, add a biologic when methotrexate is not enough. When a patient still has active rheumatoid arthritis despite an adequate trial of methotrexate, the exam wants you to escalate, usually by adding a biologic disease-modifying drug, such as a tumor necrosis factor inhibitor. The trigger in the stem is persistent active disease on methotrexate, not a brand new patient walking in the door. Second, and this is the high-yield safety point, screen before you start a biologic. Before starting a tumor necrosis factor inhibitor, you screen for tuberculosis and hepatitis, because these drugs can reactivate a hidden infection. A stem that starts a biologic without screening is a wrong answer. If the tuberculosis screen is positive, you treat that infection before the biologic, and once a patient is immunosuppressed, live vaccines are avoided. Here is our third practice question. A 50-year-old man with rheumatoid arthritis has been on the maximum tolerated dose of methotrexate for 6 months. Despite good adherence, he still has several swollen, tender joints, and his inflammatory markers remain elevated. He has no signs of infection today. His physician is considering adding a tumor necrosis factor inhibitor. The question asks for the most appropriate next step before starting it. Think about the safety screening this class of drug always requires, and be careful of the distractors that do too much or move in the wrong direction. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, the safety screen. Before any tumor necrosis factor inhibitor, the exam wants you to screen for latent tuberculosis and hepatitis, because these drugs can reactivate a hidden infection. Screening first is the safe and appropriate step, and it is the exact detail this question is built around. Now, the key distinction between the wrong choices. Stopping methotrexate entirely is wrong, because biologics are usually added on top of methotrexate, not swapped in for it. Giving live vaccines while starting immunosuppression is both unsafe and backwards. Admitting a stable outpatient just for a first dose is classic overkill. Every distractor either does too much or moves in the wrong direction. The correct answer is to screen for latent tuberculosis and hepatitis. Here is a co-management pearl that ties the outpatient picture together, and it is about working with rheumatology. On the primary care side, the exam expects you to recognize the pattern, start methotrexate, keep up the routine laboratory monitoring, manage vaccines and infection risk, and address the whole patient. A lot of correct answers are simply the appropriate follow-up step that you can own yourself in the clinic. On the rheumatology side, you refer when the diagnosis is unclear, when the disease stays active despite methotrexate, or when it is time to start or manage a biologic agent. So, when a STEM describes persistent active disease on maximal methotrexate, it is often pointing you towards specialist co-management, rather than another dose change you make on your own. Knowing which side of that line the question sits on will steer you to the right answer. That wraps up our review of inflammatory arthritis question strategy for Step 3. Remember the core ideas. Read the STEM for the rheumatoid pattern of symmetric small joint disease with prolonged morning stiffness. Confirm and treat early, and reach for methotrexate as your first-line drug. Watch the liver enzymes and the blood count while on methotrexate, and hold the drug when those values climb. Step up to a biologic when disease stays active, and always screen for tuberculosis and hepatitis before you start it, and know when to keep the patient in your own clinic versus co-manage with rheumatology. The best way to lock all of this in is to drill questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.